ahead and get started. Doesn't look like anybody ran away, so that's a good thing. I'm glad you all were able to find your way back. And so we'll spend the next 20 minutes talking about non-EM bound students. So those students enrolled in your courses who are pursuing non-emergency medicine careers. And so how do you feel about these non-EM bound students? Who has required courses? So a lot of people have required. Who has elective courses? Some electives too. So how do you feel about non-EM bound students? Yes. Yes. So sort of that unmotivated, not fully invested, maybe just checking a box to get by. Disinterested is often another word that comes up. Good. Yes. Yes. What time of year? And I have a very unscientific chart that we'll look at in a second around that. So, yeah. And so really what we'll talk about is, what are some of the benefits to you of having non-EM bound students in your rotation, and then thinking about a systematic plan to kind of help maximize the experiences of non-EM bound students during your rotation as well. And so just some general kind of points to get us started is trying to be proactive rather than reactive. And so rather than waiting to see, oh, thanks. Okay, thanks. Rather than waiting to see the names on the roster and the first day and thinking, oh man, they're all no one's going into EM, right? How can we just kind of prepare for this eventuality in advance? And really trying to change our own mindset and how we approach this, and really thinking about cultivating a desire to have these students with us, and really see it as a challenge and both an opportunity to grow yourself as an educator. And so this is my unscientific graph, but it graphs sort of student motivation over time. And so if you think about kind of, the clerkship year, there's a lot of this high motivation, a lot of high energy, students trying to figure out what they want to do. And then once they sort of figure out what they want to do and they start coasting towards residency applications, right, their motivation in your course may significantly decline. And then usually there's this small uptick right at the end of the fourth year when they're fearful, right? They're like, oh my gosh, I am going to have to do this. And so we sort of pick that up then. And so what are some of the benefits of having non-EM bound students? And so I think one is really you can help influence specialty choice. And so there are a lot of students out there who don't even really know about emergency medicine until they come to you. And it really gives us the opportunity to recruit, motivated and collaborative people that we want as our colleagues into our specialty. It can also help impact students' view of emergency medicine. We all carry, perceptions of other specialties with us, and so there may be misperceptions about what emergency medicine physicians actually do. And I know at our institution, a lot of times students are asking, well, can you also have a research career in emergency medicine? And it's yes, absolutely, and really connecting them with resources so they can see themselves in our specialty and understand how we impact the healthcare system. Promote collaboration, right? These are going to be our future consultants, right? Even if they're not going into emergency medicine, they're going to be the doctor, the orthopedist, the neurologist, whoever you're calling, at 2 or 3 in the morning. And so what are the things that they need to know to be a successful consultant for you? And really promoting those things. And it also helps to provide a seat at the table. So this provides political capital within the School of Medicine if you are a required course. And so it can be really helpful to you. And obviously, we all think it's beneficial to students, right? And so I just picked sort of the 3 areas that I think, maybe the most easily, sort of ones that are easiest to kind of see. And so I think, within patient care, undifferentiated patients, we're like a quaternary institution, right? So a lot of times students are spending time on really specific specialty services, and it's pretty rare that they have the opportunity to evaluate a patient who's undifferentiated. And so really, highlighting that and talking to them about that. Focused histories and physicals, actually getting them to think and synthesize information and not just do everything long form all the time. Really working on differentials, procedures, urgent intervention, interventions. For those of you that do use the EPAs or entrustable professional activities, like I feel like EPA 10, which is recognize urgent and emergent situations, fits nowhere better than into emergency medicine activities. You know, systems-based practice, something, you know, if you're sort of on the rising tide for thinking about health system science and health system science education, like we are just a great place for that, right? There's task prioritization, there's ED processes, there's thinking about emergency department's role in the healthcare system, there's interprofessional communication, team communication, and so we're really like ripe with opportunities to also teach our students in that domain as well. And then I think recognition of limits too. I mean, students can walk into situations that, you know, they may be unprepared for, and that's a good thing, right? Because they're still in that safe environment and still as a student, and so helping them recognize that opportunity so they know what to do, and it's not their first time on call where they're, you know, feeling uncomfortable and starting to panic, but they've had that experience as a student. And so to kind of create our systematic plan, you know, I think these are kind of the key things, right? There's the teacher, which is you. There's your learner. There's an exchange, and that all happens within the context of the learning environment. And so we'll sort of work from the things that you have the most control over to the least control over. So as a teacher, right, like you can have clear expectations and you can have a good attitude. In your learning approach, you're going to use learner-centered approaches. And then you're going to do all you can to try and optimize learning environment. And we'll have a session on learning environment. And then kind of the more difficult one is really trying to foster that motivation in your actual learner. And so set and communicate clear expectations. It's for both the clinical, the non-clinical staff, and ensure that everybody who the students are going to interact with know what's expected of the students, right? There's like nothing worse than they're like, oh, but that resident said I don't have to write H&Ps. What do I have to do, right? And so making sure everybody understands what is expected for them. Help orient them, you know, to your course, the emergency department, how emergency physicians think. It can be really overwhelming for students. You know, we live and breathe the emergency department. We see the order, like, it, you know, they don't, and it's very intimidating. It's loud, it's bright, there's lots of people, there's lots of moving parts. And so thinking about how you can really help them come into that environment. And, you know, emphasize translatable skills and benefits to them. And so we'll talk a little bit more about this when we talk about motivation, but don't like depend on the student to understand like why this is helpful to them. Just show them, tell them how it's, you know, how it's helpful. And then always inspect what you expect. Like nothing will undermine your course faster than if you have like an attendance requirement or H&P requirements and students don't meet that and nothing happens. Because then it's like, oh yeah, I was on that rotation. Yeah, I didn't write any H&Ps and it was fine, right? And then you're like, what the heck? And so if you do have expectations, like, you know, you have to actually check and make sure they are doing what you've asked them to do. You know, have a positive attitude, try and be open, approachable, enthusiastic. Practice mutual respect, right? We have to treat the students with respect. I mean, they are whole and complete persons with lives that have been lived before med school and during med school. You know their name, know their specialty, acknowledge their past experiences. Sometimes I've been surprised, you know, what some students have done before they've come to med school, and they really do bring a unique perspective with them. Acknowledge their presence on shifts, right? Like, we can't ignore them or just like hope they're going to go away because it's really busy and we don't know what to do with them at the moment. And expect competence. I think sometimes we have a tendency to, you know, not expect students or not expect those going into emergency medicine to be able to do always what we're asking or to feel like they're not going to want to. But I would say just really try and start at a place of like, you know, students do well when they can and they want to do well, and so just have that expectation for competence for them. Learner-centered approaches, again, just getting to know your students, like we talked about earlier, you know, think about, you know, self-directed learning, how to really have them capitalize on their own learning interests. You can have resources for students. The CDEM curriculum has, you know, lots of materials that you can refer students to. You know, are there opportunities for individualization of the curriculum, particularly for those who are like non-EM bound? You know, can they have a core set of shifts, but are there some locations where maybe they could pick, or for ultrasound, right? Like, if you have topics, like, could you allow the student to pick what topic they want to do rather than assign it to them? Just really, you know, do they have individual goals? Is there a way you can help meet that goal for them so they feel like they have some agency and some investment in the process? And similarly, like we talked about active learning and classroom stuff, like use bedside teaching techniques that also get the students' thoughts first, right? So like the 1 minute preceptor, snaps, things like that, where you're actually asking the student what they think and you're taking 2 minutes to actually listen, can be really, really impactful in the student experience. And so, it's about the learnable moment. I think a lot of times we think about like the teachable moment, but that's really teacher-centered, right? That's like when I feel like I want to teach. I'm like, oh, this is a great teaching point, and I'm going to deliver it to the student right now. But if they're not ready to hear what I have to say, or they're not in a place, or maybe they already know this thing that I think is like super great, right? They're like, yeah, the last 5 shifts, all the attendings have told me that teaching point, right? Like, that's not super helpful. So we really have to think about that learnable moment. When is the learner ready, and are they ready for like what we're about to tell them? So I will ask you guys to pause just for a second and reflect back on some of your least favorite experiences in medical school. We won't go there for very long, but just think about it. Bring it forward in your mind's eye. What are you seeing? What are you doing? What's around you? Where were you? What's happening? And then, if you feel comfortable, I'll just ask you to share like what made that experience not very favorable for you. What was happening? Yeah, so not very involved. Yeah. Anyone else?
It's a general surgery. I've never been berated more in my life for a procedure that he was doing. I can't remember what it was. I think it was an internal hernia reduction. And mesh. I asked him what we were doing before we got in there, so we could get up on it. He said, "Oh, don't worry, just show up." I could see people really on like multiple things. When I get them wrong, a lot of profanity, lace tigers that went on. It went on for like 30 or 40 minutes, so it's definitely the worst thing.
Yeah. How about the best thing? What was the best thing that happened to you in med school? Best rotation, best experience.
I had a day on like the week that it was a resident retreat, so it was just me and attendants. And as a third year, I was terrified going into this day of how difficult it was going to be. And I got to do so much cool stuff that I didn't get to do any other day because there were more trainers that had me, and turned out like one of my favorite days. So that's cool.
Yeah, that's awesome. Any other favorite days?
Usually patients put really cool days where you felt like you could help somebody.
Yeah. Yeah. And so I think kind of what all these things, have in common, no one said like, oh, it was the day, I learned the Krebs cycle in like year 1, right? Like, or like, the HPA access, it just, really got to me. But it's really about the people, right? It's about the people, what they say to you, how they treat you, how they make you feel, and that learning environment. And so that is just really hugely important. And so, how can we really optimize our learning environment? Recognizing, we don't always have a lot of control over things in that environment, but really trying to create and maintain that positive learning environment that both supports but challenges students, right? So you're not just sitting around all day like waiting for something to happen. And just being mindful of professional humor. What sounds like a funny joke to you about another service, right? To a student, it's not gonna sound that way. It's gonna sound unprofessional and potentially demeaning to others. And so, I know some people like gallows humor and things like that, but just really being mindful about what that's saying about us or saying about others, and if we're really conveying the right message to our students with that. And always remember, our actions are going to speak way louder than our words. And so if you're, preaching about stuff, and, you're saying do this, do that, and here's how you, talk to people, and here's how you consult, and then you're not actually doing those things, nothing will undermine your message faster. And so all eyes are always on you. And so just holding yourself to that, holding your colleagues, your residents to that, and helping them see that they really do, have a huge impact on the students just by their very presence in the department and how they carry themselves. And so we've kind of, hit a lot of the ones that are a little bit easier to kind of check. And then, the last one is sort of like, so how do we actually try and like motivate these students? And so regardless of like what theory of motivation you sort of look at, subscribe to, like to use, motivation is multifactorial. And I think really the things that all the different contemporary theories of motivation have in common is people ask themselves, like, can I do this thing, right? They call it like self-efficacy. Like, do I believe in myself that I can carry out this set of expectations of me in the way that someone's expecting? Do I want to do it, right? Like the task value of something. Like, is this valuable to me? And then what will happen if I do it, right? Like task expectancy. So like, what's gonna happen, if I do like this focus, history, and physical, or if I do try and do this procedure. And so kind of using this framework, we can sort of ask like, so how can we motivate people in the way we set up our systems? And so, one is really promoting this idea of mastery, orientation, and growth. And so giving people permission to try and fail, like setting that up as like, that's okay, that's expected, we want you to stretch yourself. Really rewarding growth. Like, I feel like not an effective teacher if someone comes in and they're like really great, right? And they leave and they're still really great, but they may not have learned anything, right? Like they got 5s when they came in and they got 5s when they came out. Like, okay, but like what have they actually learned? Versus like really trying to find people's growing edge and use that to really push them forward wherever they're at on the spectrum. And I think growth-oriented feedback is a really good way to do that. Trying to move people away from like, oh yeah, you're super smart, you have such a good fund of knowledge, right? But to like, wow, you must really read a lot. You seem to be able to access your knowledge quickly at the bedside, right? Like focusing more on that process. Like, you're a good communicator, right? Like that's like a trait state versus like, I really like the way you use that strategy in this situation, and focusing more on the process and how they got there. And really helping to emphasize the value of the course activities, like why you have different activities and what they can expect to learn from it. And you can really tailor that to like, anyone's specialty. Like most of us, we're creative, and so like you can kind of make it fit if you're, interested in anesthesia. Oh, well, here's this thing that you can do that's going to be super helpful for you in your future career. And recently we've had actually more students who have been going into like industry. We have like a innovator development program, and so they're come in with PhDs in engineering, and so they're leaving, not going to residency, but going to industry, and they have to take an acute care course, right? So like we're it. And so our residents are like, but we don't know. They're not even going to be doctors. Like, what do we teach them about, right? And I'm like, well, you put the fear of God into them, right? They're going to have MD after their name. They're going to use that in what they're going. They're going to put their credentials out there. And so, what would a lay person on the street who's non-medical expect a doctor to be able to do if there's an emergent situation? Right? Help. Go towards the problem and know what to do in those first couple minutes till others arrive. And so I'm like, just put the fear of God in them, right? Like, but you can, just trying to help people see what the value is and what you're doing. And so here's just a brief case. It hopefully sounds familiar to most, but you come on for your night shift, the department's busy, you notice there's a student who's sitting in the physician workroom, they're checking email on the computer. You get sort of pulled into a room with a sick trauma resuscitation, and then you kind of make your way back to the workroom, and the student is still there, the email is still open, you're pretty confident they haven't moved or done anything while you've been off resuscitating trauma patients. And so how would you handle this situation? Mm-hmm. Yeah, good.
Sometimes giving them that permission of, you should go and join this. Like if you see people running over to this room, like, we want you to learn, come join us in that room.
Yeah, and I think that's like if you have time, I think that's a really nice approach. Like not making assumptions, right? Like the easy assumption here is like the student doesn't care, right? They're disinterested. They're just sitting on their email, and so I think that's sort of like open approach of I noticed, right? Like what did you observe? I noticed that you were sitting at your computer when I came on my shift, and now it's an hour into the shift, and I noticed you're still at your computer. And then just wait, right? Like I'm a big proponent of like just saying something and waiting, and and see what they say back. And maybe it is I just got this really email, or oh I'm sorry I didn't know I was supposed to go to that trauma resuscitation, right? And it gives you that option to kind of clarify expectations. And so, any thoughts? I think some people provided thoughts like assigning residents or faculty and making sure they know the residents and the faculty what they're supposed to do with the students, right? Can help prevent this. And so hopefully maybe a resident would have seen the student and been like, hey, you're supposed to come to resuscitations. Let me show you where the resuscitation is taking place. Can be really helpful. But any other thoughts on how to kind of prevent this situation? And I think your comment too, like empowering them in the beginning, like, and I always tell my students, like if you see people running in the emergency department, you should follow them. Like I promise someone will tell you if you can't be there, but just get up and follow them because something is happening and you probably want to see what's going on. But any other thoughts?
Try to set really clear guidelines of orientation of what we expect from the nurse.
Yeah.
As you can imagine with my experience in the OR and those families,
Yeah.
that always be very uncomfortable. We have a very comfortable faculty to work with, and so fostering that so that they can ask questions and they feel comfortable like exploring and really see what's going on and try to set that really comfortable.
Yeah, that's great. All right, and so in conclusion, having non-EM bound students is beneficial to you, to the students, as well as to our specialty as a whole. And really having a systematic plan can really help maximize the learning, really of all students, through clear expectations, a good attitude, more learner-centered approaches, thinking about the learning environment, and thinking about ways to really help foster motivation. So, questions?
Do you have examples of how you've leveraged their experiences if they're going into a non-EM field for the betterment of your course for the EM students?
For the betterment of our course for the what?
For the students who are EM.
So I think usually sometimes that's around consultancy, right? And so like if you have people like going into ortho, who've taken a lot of ortho rotations, right? Like they're usually really excited about like radiographs and joint reductions. And so using them or tapping them to like, or creating opportunity for them to teach the EM bound students, right? And then asking, okay, so if that EM bound student, if you're gonna call this future orthopedist, right? Like what is the future orthopedist gonna really wanna know, right? And how do they package that information? How do they wanna hear that information? And so trying to engage, the non-EM bound student around their interest, and I think consultancy just kind of provides a nice way to foster that conversation. So what have you learned, like you've been a lot on ortho, so what have you heard the orthopedic residents say when they get calls from the ED? What makes that consultation easier for them? Or what makes it more difficult? And just trying to use